Hi, everyone. Welcome to Podcasts for Patients with the Aplastic Anemia and MDS International Foundation. I'm Lee Clark, Senior Director of Patient Programs, and I have the pleasure today of speaking with Dr. Richard Childs, who's the Scientific Director of the National Heart, Blood, and Lung Institute at the National Institutes of Health. Dr. Childs also serves as the principal investigator for clinical trials for patients diagnosed with aplastic anemia. Before we get started, I'd also like to thank our diamond level sponsors, Alexion, Apellis, and Novartis, as well as our patients, families, and caregivers, who without their support, this podcast would not be possible. Welcome, Dr. Childs. Thank you so much for joining me today.
Good morning. Good to talk to you this morning.
So before we get started, tell me a little bit about what is aplastic anemia?
Well, Lee, aplastic anemia is a very rare but very devastating disease that affects the bone marrow, where there's a diminished number of hematopoietic precursor stem cells in the bone marrow. And in most cases, we think it's an autoimmune disease. And because of the lack of these hematopoietic stem cells, patients develop cytopenias, they develop anemia, their platelet counts are low, and their white blood cell count is low. They're susceptible to infection, bleeding, and to severe anemia. And if untreated, the disease is uniformly fatal.
Dr. Childs, what are the current treatment options available for patients?
There's two principal modalities to treat patients with aplastic anemia. One is immunosuppressive therapy to try to turn off the immune cells that are suppressing the bone marrow to allow them to grow back. And then there's bone marrow transplantation, where we take a donor that is tissue matched or HLA compatible, and we collect their stem cells either through a bone marrow harvest or through a procedure where we collect the stem cells from the blood, and we give them immunosuppressive therapy and then infuse those stem cells back. That type of bone marrow transplantation could use brothers or sisters that are tissue compatible. You can also use matched unrelated donors. And now more recently, there's an option to use family members that are only partially matched. Cord blood transplantation historically has had sort of mediocre results for aplastic anemia. The problem with cord blood transplantation is the stem cell numbers are very small. And because of that, when you use cord blood, it usually takes about a month before the blood counts start to recover. And the longer it takes, the higher the risk of the transplant procedure in terms of getting infections or having bleeding complications. And that's why up until recently, cord blood transplantation is really sort of moved out of favor as a transplant option for aplastic patients.
What led to the investigation of Omisirge?
Well, I and my team have been exploring ways to try to improve the results of cord blood transplantation for aplastic anemia for about 20 years now. And our last trial before the Omisirge trial had used a combination of a single cord blood unit and haploidentical stem cells combined, and that resulted in pretty good results. We had about 84% of patients that were cured with that approach, but it was complex. It involved two stem cell sources, logistically difficult to pull off, and not something, that any transplant center could do because of the logistical challenges. So we were very interested in trying to find a way to use a single cord blood unit to improve the results, to move away from two stem cell sources. Omisirge, also known as omidupacel, had been developed by the Gamida Corporation, and they had some very interesting technology where they could take a cord unit, put it into the laboratory, and then in vitro expand up the stem cells over about a 3-week period using a combination of growth factors and other chemicals to keep the stem cells from differentiating. And they had shown that this expanded cord blood product, when given to patients with acute myelogenous leukemia that were undergoing cord blood transplantation, very good results where they had very rapid recovery of the hematopoietic system and where their neutropenia or low neutrophil count recovered in only 12 days, which is much faster than the typical 25 to 30 days with the cord unit. And based on those data, omidupacel was FDA approved for treating patients that had hematologic malignancies over the age of 12 that were undergoing cord blood transplantation. So we got very interested when we saw that data that was published at around 2021, that this could be a strategy to improve the results of cord blood transplantation for patients with aplastic anemia. The goal to use an expanded cord blood unit was, the thought was at least, that if we had a lot more stem cells in the expanded cord unit, that would not only improve or shorten the time for neutrophil recovery, that would translate into less risk of infections associated with the transplant, but also would reduce the risk of the transplant being rejected, because there's very clear data that the higher number of stem cells that you transplant, the better the transplant outcome and the lower the risk of rejection. So our hypothesis was that if we applied Omisirge to the transplant component in patients getting cord blood transplantation with aplastic anemia, that the transplant results would improve. And then the other thing that's interesting about cord blood transplant, the real attraction, is that you don't have to have a perfectly matched cord unit to have great results. You only need to have a partially matched cord unit. And for patients that don't have HLA matched donors, or even half matched family donors, they can serve as a stem cell donor. This really opens up a large pool of potential donors that could utilize cord blood transplantation as a donor stem cell source. So for all those reasons, we decided that we would move into a clinical trial to explore whether Omisirge could have good results in patients with aplastic anemia that was really severe. Because it was the first in human trial for aplastic anemia, we restricted the study to patients that had aplastic anemia, that were transfusion dependent, and they also had to have failed immunosuppressive therapy. And those are patients that have higher risks of transplant. They have higher risk of rejection. They have worse survival rates. So we wanted to, for our initial trial, restrict it to patients, since we didn't know much information as to whether it would work in a population that was higher risk, that would justify that big unknown of the trial.
What were the results of the trial?
So we have so far transplanted 20 patients, and the results have been far better than anything that we expected or anticipated, given the high risk of the population that went into the study. And when I say, high risk, all 20 of these patients had failed immunosuppressive therapy. They were very heavily transfused. They were iron overloaded from those transfusions, and that's known to increase the risk of a transplant. Basically, what happened was that we were able to expand the cord unit for all 20 of these patients. The stem cell numbers that were contained in those cord units were substantially higher than what was in the non-expanded cord unit, about a 38-fold expansion of the stem cell component. Remarkably, because of having that higher stem cell number, we saw really, really great engraftment results. 19 of the 20 patients had engraftment, and that engraftment time, very, very rapid, occurred at a median 11 days, again, which is much, much quicker than you would get with a non-expanded cord unit. And 19 of the 20 patients survived or transfusion independent. Patients had platelet recovery that occurred about a month after the transplant. That's also pretty quick after a cord unit. It's more typically in the 45 to 60 day with the non-expanded cord unit. When we looked at something called chimerism, where we can look and see what is the origin of the hematopoietic stem cells in the circulation after the transplant, we found that the immune system from the cord unit, in terms of T cells, engrafted very, very quickly, with the patients becoming 95% or higher donor T cell full chimeras by only 21 days post-transplant. So rapid engraftment, sustained engraftment, transfusion independence achieved in those patients. And then really the two other remarkable things were that we didn't see any severe graft versus host disease, which is a known complication of bone marrow transplantation. And when we grade it from grade 1 to 4, we only saw about 16% of patients that had grade 1 or 2, which is the minor GVHD, but we saw no patients that had the severe GVHD, grade 3 or 4. And The other remarkable thing was we had no patients who developed chronic GVHD, which usually occurs in somewhere between 20 to 35% of patients. The other thing that was remarkable was the immune system recovered very, very quickly in these patients. And when I say quickly, I mean the CD4 counts, which we look at in everybody that gets a transplant. It came back much quicker than we see with any of the transplant modalities that we've studied at the NIH. Also came back quicker than historical published data with cord blood units that don't involve expanded cord, and came back quicker than was published historically with patients undergoing half-matched or haploid transplants. We also saw some other interesting immune cells that came back quicker, like natural killer cells. They really recovered super quick early on. We know those natural killer cells are produced from the stem cell population. So we think lots of stem cells produce lots of natural killer cells. We think those natural killer cells protect the patients from infection and also help to ensure that the transplant engrafted, had sustained engraftment, and prevented any late graft rejection. So I have to say the results far exceeded anything that we anticipated. And because we were seeing such great results in high-risk patients, the company that produces the cord unit, Gamida, went to the FDA and said, hey, could you take a look at these interesting data coming from the NIH and see if you think this is sufficient to warrant a label change on the product? And the FDA came, reviewed our data, and then granted a label change and FDA approval for the product in December of 2025.
And how does this new approval change transplant options for patients?
So it adds an additional option for patients that don't have an HLA matched donor. Sort of the algorithm that we follow when we do bone marrow transplants or stem cell transplants for patients with aplastic anemia is it's great if you could find an HLA identical sibling or an identical twin. Almost nobody has identical twins with aplastic anemia. It's very rare. But an HLA identical sibling, we find in the range of 20-25% of patients with aplastic anemia. Matched unrelated donors are another good option, but a significant amount of patients don't have matched unrelated donors, particularly minority populations. And then once you get to the point where a transplant would be indicated could help you, but you don't have a donor, that's where Omisirge could be a potential benefit to patients because it is now an option to take a look, get the tissue typing, the HLA data, and look, is there a potential cord unit that could be used, that could be expanded up and used as a stem cell source for patients with aplastic anemia. So it adds another therapeutic transplant stem cell source option to patients that don't have HLA identical donors.
Are there any additional benefits or risks that you would like patients to know about?
Yeah, I think that the data that we have right now is extremely encouraging. But I would say the disclaimer is that we've only transplanted 20 patients. Granted, they were high risk and transfusion dependent, and many of them had very severe neutropenia and had HLA antibodies, which increase the risk of rejection. But despite having those HLA antibodies, in our case, 75% of the patients had HLA antibodies, we didn't see any rejection. But if somebody has those HLA antibodies, when you're picking the cord unit, you have to work around those antibodies and pick a unit where that antibody is not going to be a problem. And you also have to pick a cord unit that has a sufficient number of starting stem cells in it. So there is an art, to picking that cord unit. In some cases, when we do a preliminary search, we may find that there are many, many potential cord units that we could use. But you do need to have an HLA expert. In most transplant centers, we'll have these HLA experts that can look and say, okay, the prerequisite to having a cord unit that could be expanded is that it has to have a sufficient starting number of stem cells and that there are no HLA antibodies that would cause a problem. And then you say, okay, that's a potential option. Now let's see how many of those we have and which ones are the best match. So there is an algorithm that goes into trying to pick the best unit. In terms of other things that I would tell patients considering different transplant approaches, is that the data look fantastic so far, but again, it's a small study, and we'll have to see how these results look when we start to get larger and larger numbers of patients that are enrolled. The last thing is it does take about 6 weeks from the time that somebody gets referred to us to when we can do a transplant. We're not able to immediately jump into a transplant because we have to identify a cord unit. That cord unit has to be shipped to a facility where it's expanded and then shipped back. That whole process is about a 6-week process. So for patients that really have a super emergent indication for transplant, sometimes you'll have patients with active fungal infections where you just want to transplant them immediately and get the neutrophil count to recover. In that kind of a case, this may not be the best transplant option. For the majority of patients, though, that don't have that urgency, I think that this expanded cord unit approach with Omisirge is really viable therapeutic option that needs to be considered when a patient sits down and talks with their transplant physician.
Is there anything else that you'd like patients to know?
I anticipate in the future that there probably will be a trial that may compare a transplant that uses Omnisirge with a more conventional transplant approach. Right now, I would say that if you were to do a head-to-head comparison, what would be the approach that you would compare to? It probably would be to the half-match haplotransplant approach. There was a recent trial that compared non-expanded cord units to haplotransplants in patients with hematologic malignancies, and the cord unit patients did worse, and they had lower survival. Now, with the ability to expand those stem cells up, to shorten that time to having neutrophil recovery, to improve engraftment rates, I think it really makes people interested again and saying, hey, maybe this is the way to make cord transplantation a viable option. So I think people are going to become very interested in comparing an expanding cord unit approach with the more conventional transplant approaches. And when those trials open, I would encourage patients, if given the opportunity, to participate in those trials, because we don't have an answer as to which is better. The results from our single study look great, but historically, single institution studies where there's a lot of expertise, in transplantation, the data from those studies tend to be very, very good, but when you go to a randomized trial, the results are not quite as good as in the single institution study. So I would tell patients, discuss this as an option with your doctor if you don't have a perfectly matched donor. And if given the option to participate in a clinical trial, to strongly consider that, because I think that Omnisirge is a definite viable option with extremely encouraging data coming out of the gate from this first-in-human study.
Thank you so much, Dr. Childs, for sharing your time and your expertise with all of us today. And if you'd like to learn more about aplastic anemia and all the current treatment options that are available, please visit our website, which is aamds.org, or give us a call at 800-747-2820. We're happy to answer all of your questions that you may have about aplastic anemia and the treatment options that are available to patients. Thank you again, Dr. Child, so much for spending your time with us today and answering all of these questions.
Thank you very much, Leah. I would also tell patients that, we have multiple clinical trials at the NIH for aplastic anemia, and this trial is still open. That's something to consider as well. Thank you.
Wonderful. Thank you so much and have a great day.
Thank you. You too.